welcome everybody. Another evening of understanding. Now, one of the things that's interesting is that family history, genetics. How does that fit into knowing what's wrong with yourself? So it's interesting today. I'll tell you a little story at the end. Is that I spoke to one of the family doctors today, and I knew exactly how to treat my son's lipid problem or what's going to happen to the future by knowing some genetic factors. And I'll explain it as we go along the way. So Dee and our team are really prepared a really nice story about family history and genetics. So Dee, take it away. I'm really excited to hear what you have to say.
Yeah, so today we're talking about family history and genetics, why it's important, and especially why it's important to start off the new year with a little bit of awareness and coming together with your family. So I believe, Dr. Kearney, you wanted to share a little bit of a story.
Oh, yeah. So this is a couple things is that we're starting to do the stairs again. So my weight's gone back up. It's coming back down. And last night, this is Stuart and myself at climbing up the stairs. And so Stuart, I'll catch up to you next time. And that's great. We had a lot of fun climbing. I think we did it 6 times, so that was pretty good. And this morning I did it with Adam this morning. So Adam and myself are every Mondays and Friday mornings at 6 a.m. We're climbing the stairs between 6 and about 6:45 or so, when we get too tired. I don't tell that to Adam. So anybody wants to join us at the Shadok Stairs, we're going to do this on a regular basis. So obviously, if the weather's terrible, we won't go there, but great way to start the day. And then student others, if when we finish on a reasonable time, we're going to go on the nighttime. So what I'm going to do is I'm going to do a monthly 6-minute. Oh, thank you so much. So what I encourage everybody, want to grab a spoon for me? Yeah. So what I'm encouraging everybody will be here is to have some soup and have your dinner during the meetings here. So I'm going to have some nice vegetable soup. Elizabeth brought me in some nice ginger soup with lots of vegetables. So I'm encouraging people just to eat well and to be healthy. So for the eating part is that I need an entourage to help me find the right foods. And for exercise, the same thing too, I need an entourage because I have bad genes for heart disease. And I know how to fight them well, and I'm going to hopefully we can show you some things too as well. So on Mondays and Friday mornings at 6 o'clock, we're doing the stairs on a regular basis. Thank you so much, guys. And other days of the week, we're going to do other forms of exercise as well. So this summer, I was cycling and tennis. The winter, I'm going to do the stairs and maybe some cycling depending on the weather. So and I'm going to do is every month, I'm going to actually test myself to see if I'm getting better. So my test is, I encourage everybody to do a 6-minute test of some sort, as a walk test. And if you look at the webinar that we did last week, or the webinar we did the beginning of January 2021, we talked about exercise and exercise prescription exercise. So I'm encouraging everybody every month to do a form of a fitness test. My fitness test is how many stairs I can climb in 6 minutes. So that's how I'm going to judge myself. And my long-term goal is to just keep climbing stairs, keeping active, and retire when I turn 100. So that's my goal right now. Will I make it or not? I'm not sure, but I'll give it a shot. Dia, take it away.
Sorry, I was having some trouble unmuting myself. But yeah, so we were a little inspired to also share some of our health goals, some of our New Year's resolutions. So Aditi, do you want to start?
Sure, I can start. So I do this thing with my housemates. I live with 6 other girls where we've all been trying to motivate each other to exercise. So we started this last January, and then we kind of stopped over the summer and then got back to it in November, and we started again, I think it was like 2 days ago. But we basically make a pact each month where each person, like every day that they exercise, we have to send a photo of us exercising to our group chat, and then we each get a point. And last year what we ended up doing is the winner was bought like a coffee or something by the person who lost that month. ever since like COVID hit, we've kind of changed it. So we do, for any day that you don't exercise, we donate like $1 to $2 to the charity of the winner's choice. And just like that competition element helps keep all of us motivated. I find that when I don't have like other people working out around me, I find it a little bit harder to kind of motivate myself to actually start. So we kind of got back into it within the last week, and that's kind of the goal, is to just keep up with it and make use of the support system and support my fellow housemates as they start their exercise journeys as well.
Excellent.
That's awesome. For me, my goal was to get outside a little bit more. I know that sometimes I can just be trapped in my own house. It's so comfortable and warm and nice. But one thing that I really love for exercise is skating. I always loved skating, and I used to skate all the time at my local skating club. So we found that with lockdown, it's a little harder to access rinks, but ice trails are still available. So my sister and I drove up to Muskoka, and we did a socially distanced ice skate. A couple of rounds on the trail was around 10 kilometers. So it was really great, and a form of vitamin D. It was awesome and really, really fun.
Beautiful.
So for me, I live like right by the Rocky Mountains, so that's something that I've been enjoying and I should take more advantage of. My goal, like for the new year, is to get out more and exercise and kind of walk on these trails as much as I can and enjoy the scenery, which, you know, I've been kind of putting off because staying at home, like Dia said, is too comfortable. But yeah, that's what I'll be trying to do.
You know, I think this is amazing how people are adapting. So, you know, is that you can be across Canada and still be in communication. And I remember when the lockdown first started, and the sense of isolation. I was just listening to a story today that just warms the heart. So this, when the teachers were going back to school with the kids, they were scared. We all get scared. I get it. But now we're adapting, and this kindergarten teacher from Kitchener, I have to thank her for this wonderful story. I'm driving to work this morning after we climbed the stairs, and she tells us she realizes that her internet is down, and she had this class to give to her kindergarten students. And so she did. She drove to Tim Hortons, got the Wi-Fi there. She still had her slippers on, delivered her course, and she was singing and dancing in her car in the Tim Hortons parking lot in her slippers, and delivered her lesson as a kindergarten teacher. So there you go. So different ways of adapting. And at one time we were all afraid. It's okay to be afraid, but it's also more important to adapt and to find new ways of doing things right now. And for many people, activity has been a problem. And you can notice that for most of us, if you look in times of stress, being outside and being active is probably the best antidepressant and anti-stress medication you can prescribe. So if I can prescribe one thing for everybody, get outside safely and do some form of activity, I feel so much better, so you will as well. So one thing we're going to talk about is genes load the barrel, but you pull the trigger, and how you interact with your environment. So we're going to learn more about that. Thanks for sharing that.
Yes, exactly. So today we're just going to go through a really quick outline of what we will be talking about. The first is how to understand family history and how to keep track of your own family history. We'll then move on to explaining DNA, genes, and defining different types of genetic conditions. We'll also talk about polygenic risk scores and explaining risk. We'll move on to the Framingham study for calculating risk. And then we'll touch upon types of inherited conditions, both cardiac and non-cardiac conditions. And finally, we'll explain some resources for identifying cardiovascular conditions in your family and what to do with that information.
So understanding your family history is extremely important, and the reason why it's important is because it helps both us and our physicians understand the risk we possess for different types of diseases and conditions, which can inform the way we and our physicians address our health, approach any lifestyle changes, And family history is more than just genes. So family members share genes, they share environments, lifestyles, and habits. So you can't change your genetic makeup, but knowing your family history can help with risk reduction by informing the way we're able to make changes about our lifestyle, and also screening practices so that we're able to identify these conditions early on. So just a couple of things to note in your family history. You want to make a note of diseases that occurred at an early age. This is typically 10 to 20 years before an average person would experience this type of condition. That could indicate that you're at a higher risk for it. Diseases in more than one close relative. So when you talk about family history, we talk about different degrees of relatives. Your first degree relatives are your parents and your siblings, and then second degree is onto like grandparents, aunts and uncles, etc. So thinking about the close relatives and how many people possess the same kind of disease can also inform the amount of risk you're at. And then disease combinations, so different combinations of diseases that could act as comorbidities for one another. That's something to note too. So examples like diabetes and heart disease, both of those run in your family, something to make note and to inform your physician of. And then another thing to note is sex, ethnicity, and lifestyle, because these are all factors that kind of influence the way diseases and conditions might affect a person. So there are some conditions that might be rare in one type of ethnicity but are more common to another type of ethnicity, or maybe the condition is more common in females than it is in males, or sometimes certain things you do in your lifestyle. So for example, if smoking is part of your lifestyle, you might be more predisposed to certain conditions. And if you had a family member who was a heavy smoker and they developed a condition as a result, that's something to take a note of as well. And lastly, taking a look at mental health, so mental illnesses as well as alcohol and substance abuse and pregnancy complications. That can actually, it's important for your physician to know, because it can also influence the way that they might approach treatment or approach suggesting any lifestyle changes that you should make.
So let's just pause for a second here. If you go back one slide. So we talked about knowing what's in your family. So you said something really important. Number one, first degree relatives, closest to you. So the ones that are closest to you, you'll share the most genes with. So it includes your parents and your brothers and sisters. So so number one, and then we talked about second degree relatives, grandparents, aunts and uncles. So that's really important to make those distinctions, and the more family members with a condition, the more likely you're going to have this problem yourself. I'm going to share that I have a very bad cholesterol problem in my family that's seen in my father, aunts and uncles, cousins, brother, sister. We also have genes for diabetes. And right now is that my brother has diabetes, my dad had diabetes, I don't have diabetes. And I share a lot of their genetic traits. I have high cholesterol, but I treat it. I have something called high LP(a), which is a genetic marker seen in about 20% of the population. Guess what? My son has it. And interesting, he should start on cholesterol medications at the age of 20 because of his genetic marker. His family doctor doesn't feel comfortable starting on that. That's okay. That's what I'm here for, to help guide that therapy. So really knowing your risk. So remember, look at your family tree and go down and record this. Ask friends, relatives, other people, you get as much detail as you can. It's really important to say, I know there's breast cancer in my family, or there's Alzheimer's disease in my family, or there is heart disease in my family. For instance, if you had your father or your mother had Alzheimer's disease at the age of 50 or below that, around that age, that's a marker for a genetic factor. Unfortunately, in an 85-year-old person developing Alzheimer's disease is all far too common, and that has a less genetic risk to that. Same thing with heart disease. If you have a brother or sister who has heart disease, or you have a parent who has heart disease at the age of 55. So a family history would say is that, for instance, my dad had angina and a bypass operation at the age of 50. That's a marker for risk. And my grandfather had a stroke at the age of 55. That's a marker for risk. If you say your father had a heart attack at 75, that's a less risk factor for you. So we'll explain that a little bit more. So really be attentive, and this is where the details come into play. Thanks so much. Next slide, please.
So compiling family history and heart disease, so I'm going to talk a little more specifically about things to note about heart disease. So a complete record of your family history is usually about 3 generations. It's unlikely that you're going to be able to compile like all of that information. I, for one, know in my family we don't always talk about health, so to me sometimes I have to sit there and like scratch my head to actually think about the family history that I have, but even an incomplete record can be extremely helpful to a physician, so try to figure out as much as you can and present that information when possible. So this is a quote that I got from the Harvard Health Journal, and they actually said that your family medical history is a key but complex risk factor for heart disease. So for heart disease specifically, start with first-degree relatives, so parents and siblings. Did anyone have a heart attack or a stroke? Was it fatal? Did it happen at an early age? And the journal defined the early age as less than 55 years of age in men and less than 65 in women. If there are no cases in your first-degree relatives, you can look beyond. So grandparents, while they're not the best predictors in terms of like genetic risk, if there is a history within your second-degree relatives, there is still a potential risk, and that's something that can be evaluated. There are other factors to consider as well. So age. I don't know why I said not there, but age, sex, ethnicity, home environment. And family history is a combination of genetics, environment, and lifestyles, so it goes beyond just your genes. You share a lot with the people around you, including like the type of environment you're in, and you're influenced by the lifestyle of those around you, and you adopt that into your own life as well. So those are things to also take into account when you're compiling your family history. So this slide's just about how physicians are able to use your family medical history. So they can assess the risk for certain diseases, recommend changes in diets or other lifestyle habits to reduce your risk of developing a certain disease, recommend medications and treatment for risk reduction. So for example, if you have a genetic marker for high cholesterol, recommending starting cholesterol therapy early. Prescribe diagnostic tests. So one example would be with conditions like cardiomyopathy, which could be inherited through families, prescribing tests like an echo to kind of monitor the heart muscle over time, and then determining the type and frequency of screening. So does that mean you have to get screening every year, every 1 to 2 years, every 3 years? That's something that they can use your family history to determine. And also determining whether genetic testing is required. There are certain genetic conditions where you have a pretty high risk of passing it on to your children, so sometimes physicians or genetic counselors might recommend genetic testing before making decisions about family planning. It can also be used to identify conditions that may not otherwise be considered. For example, if you have a family history of a really rare disease, the doctor might not think to look for that rare disease without the information that it actually runs in your family. And then identifying other family members who are at risk and encouraging them to get screened for these conditions as well, and assessing the risk of passing the conditions on to your children.
I guess this is a typical family tree. You can see, I guess, we're the males, we're the boxes, we're the square people, and the women are more creative. But I also put on the right this beautiful picture of the heart, and I thank Adam for giving me this. Reminds me, is way back when good medical observations were made, and at that time autopsies were done quite routinely, and you can see very detailed pictures of the heart and drawings were made about this. We're now starting to replace that with DNA, but we can also replace that and still use extremely well just your family tree. So here's an example where mom in purple has this disease that affects her son and passes on to a carrier to one of the other sons, and an affected daughter of the son gets this condition passed on. And so this can be anything from, a cancer diagnosis, it could be from Alzheimer's, it can be from heart disease and different factors. Now, one of the things I have to remind everybody is that we've been waiting for genes for the last 20 or 30 years. Genes have made some impact, but they haven't made the greatest impact as we anticipated, because the same gene in one person may express a disease. For instance, I have genes for diabetes. I haven't expressed disease. I have the same genes as my brother and my dad. What have I done differently? When my dad was quite skinny, I got down to my fighting weight, and I exercise a lot. And my biggest prescription, as we talked about, or one of them, is that I do pay attention to diet. I do pay attention to activity. And I think these are factors that are so important. And also, you have to have some little luck along the way. And I'm fortunate to have a wonderful environment that allows me to do the things that are most important to me. So I want you to think about is take a picture of this, go out there and be a detective and complete your own family history, but put details. For instance, if as I said to you, is that my dad, first presentation with heart disease, he had 3 blocked arteries, had a little bit of angina at the age of 50. That's important. Another one of my family members is that on his side, his father had a stroke around the age of 60. On my father's side of the family, there was everybody has these cholesterol and triglyceride problems. So my aunts and uncles and cousins all have cholesterols of 5 to 8 range, triglycerides in the 5 to 8 range. And my son and the other family members have a high Lp(a), so we have this cholesterol problem on top of that. So you have to be, and then on my mother's side, they live to 100. But we also have Alzheimer's disease on both my mother and father, or dementing illnesses. But they occur relatively late in life, in their 70s and 80s, so that has a less genetic component to that, has a more of an environmental component. We think at this stage. So lots to learn about. So please spend time to actually write this down in great detail and take some time to figure this out. If you ever go see a genetic counselor, they're going to spend a lot of time finding out problems. If anybody in your family has died suddenly before the age of 35, that's a big red flag. And if you have 2 family members who have breast cancer, guess what? You need to think about how to protect yourself as well and to know what to do about this. And you can start off with just, instead of complicated genetic markers, it's just simply good detective work. I'll be quiet for a little bit. Next slide, please.
So there's just some tips on starting the new year, keeping the entire family healthy and aware. So one is to have conversations about health and the goals that you are setting. It can be difficult to kind of initiate these conversations. Health is not something people always want to talk about, but try starting to have these conversations, because that's how you get to know about your family history and how you make others aware of it as well. And then make your goals and resolutions fun and try to incorporate family input. That way there's kind of a group sentiment to everything that's being done, and you can try doing things together as well. There's actually some evidence to suggest that having family meals inspires healthy eating habits when you're on your own. So trying to incorporate some of that might be helpful, and activities and exercise as well. Having that sort of support system can really kickstart your resolutions in terms of getting you to do the actual activity. And make your goals mindful. It's okay to start with a really small goal and build it up over time. That might likely lead to a better habit formation pattern than if you start too big and aren't able to achieve it. And make your health a priority. So at the end of the day, you're doing all of this for you, so making it a priority just puts another incentive on taking the time to actually figure out what health goals you want to achieve and how you want to approach your health, and making sure that you're doing the best you can for yourself.
Okay, so that was awesome. Thank you, DT. And now we're just going to be getting into a little more science. So we can understand our family history better when we understand DNA. All organisms are made of trillions of tiny parts called cells, and every single cell in our body contains a full set of DNA that's required for that organism. DNA stands for deoxyribonucleic acid, which is a huge word. It's a huge word for a complex molecule that contains all the biological instructions that we need to build and maintain ourselves. So it's made of a chemical building blocks called nucleotides as well. And each person's full set of DNA has about 3 billion nucleotides. And these nucleotides code for about 20,000 different genes. And we'll explain genes a little bit later on. Technology is amazing, and scientists can now do something called DNA sequencing. This is a process that determines genetic information carried in a particular DNA segment, such as determining which stretches of DNA contain genes, such as genes that might cause disease, and which carry out instructions for regulation, which means turning on and off genes. And did you know that your entire genome can actually be sequenced for just a few $1,000s? The National Human Genome Research Institute hopes to promote technologies that can allow you to eventually sequence your entire human genome for less than $1,000. So now we'll move on to genes and genetic variants, and we'll get a little bit more into that terminology. Our DNA creates sequences which are called genes. Genes code for a specific trait. For instance, there are genes that specifically code for your eye color, your hair texture, the length of your fingers, and everything else that you might not be thinking about on a daily basis. Genes exist, but there could be variants of the same genes, and these are called alleles. Alleles are variants that can arise from mutations in parts of our DNA sequences. What do we mean by mutations? Mutations are changes that occur in the nucleotide sequence of genes, and they create a different variant of that gene. They're the main cause of diversity among organisms. For example, did you know that at one point throughout human history, we actually lost the ability to make vitamin C because those genes stopped functioning in humans long ago? A genetic researcher in the University of Pittsburgh suggested that our ancestors probably ate so much fruit that we actually didn't even need to make our own vitamin C. So it's a small example of how our genes continue to change, even with our environments around us. And finally, every person inherits 2 different alleles of every gene, one from each parent. The body ends up selecting one of the 2 alleles depending on what's more dominant or favorable typically. For instance, brown eyes are a dominant gene. So if you have one parent with brown eyes and one parent with blue eyes, you'll end up selecting the allele for brown eyes because it is more dominant. Understanding genes is important for us to comprehend genetic conditions and genetic disorders, because these are diseases caused by a change in DNA sequences as a result of mutations. We can classify genetic disorders broadly in 2 categories, monogenic and multifactorial. Monogenic diseases are caused by mutations in one single gene. Some examples include sickle cell anemia, cystic fibrosis, and Huntington's disease. Multifactorial diseases are also known as complex diseases, and these are caused by a number of gene mutations and environmental factors, so they're a little harder to pinpoint. Some examples of these are many types of cardiovascular disease, cancer, diabetes, and these are also more common in society because they're influenced by our environment. There's also different ways to get your genes tested. The first one is molecular genetic tests. These look for changes or mutations specifically in your genes. Some molecular genetic tests only look at one gene, which are called single gene tests, and others look for mutations in several genes at the same time. These are called panel tests. Molecular genetic tests are also used to diagnose really similar syndromes such as cancer. And these include tests that look for changes in chromosomes such as missing or extra copies or rearranged parts of chromosomes. Another common type of genetic test is a biochemical test, and these look at the structure and amount of proteins and enzymes in cells. So most commonly, these are types of tests that are ordered by your physician if they see that your family history requires some type of genetic testing, but you can actually get tested from a private company. And you've probably seen advertisements all over your TV or YouTube, Ancestry.ca and 23andMe. So these are services that are marketed towards the customer, where you buy a home test kit, you send a saliva of sample back to the company, and you can actually get your genome sequenced or part of it right at your fingertips. So they're also building technology so that you can get your whole entire genome sequenced, and this you can do completely privately and outside of the healthcare system. And finally, we talked a little bit about this, but whole genome testing is also something that's newly coming to the table. So you can analyze a person's overall genetic makeup using whole genome testing. And researchers usually use this to try and see if this can prevent, predict, or treat types of genetic disorder. Whole genome testing is used for different purposes, such as determining paternity, ancestry, a person's risk of disease, such as cancer, or a person's response to a particular treatment. And they're not only available in the healthcare system, they can be, but they're most commonly available outside of the healthcare system, and you have to pay for it. For example, Life Labs does offer whole genome testing. Something else that we also want to kind of address is the concept of risk scores. So we can use our genetic information to calculate the risks of us obtaining genetic conditions. For multifactorial or complex diseases, we can use something called our polygenic risk score. This is a risk score that identifies our relative risk for a complex disease, which means that it tells us our risk compared to others with a different genetic constitution. For example, there might be two people with high polygenic scores for having coronary artery disease. The first person is 22 years old and the second person is 98 years old. Although they have the same polygenic risk score, which is determined from their genetic makeup, they will have different lifetime risks of the disease. Therefore, polygenic risk scores show what happens with your genetic constitution. However, they only show these correlations and not necessarily causations, which can be influenced by your environment. So why are polygenic risk scores important? Polygenicity means that complex diseases such as Parkinson's and coronary artery disease arise from thousands of genetic variants. Understanding your risk score can determine your potential susceptibility to that genetic condition. And it can help you consult with your physician on how to reduce your risk for disease progression. One limitation, however, is that genetic studies have typically been done on Europeans and those of European descent. So therefore, for individuals of colors, the information might not be as accurate as there are not as many studies to contribute to the algorithm which determines these risk scores. If you are interested in getting your polygenic risk score, you can consult with your physician where you can get genetic testing, or you could use outside resources such as 23andMe and Ancestry.ca, which we described a little earlier. However, it is always recommended to consult with your physician as well, because outside sources, which are directly to the consumer, claim to have about 80% accuracy, although they are an amazing tool for getting genetic testing. Something else that's really important for calculating risk is specific for cardiovascular disease. This is something called the Framingham study for calculating risk. This calculation was obtained from a longitudinal observational study in the USA that began in 1948, and it's called the Framingham study on calculating risk. So that was a long time ago. This goal of the study is to identify common factors or characteristics that contribute to cardiovascular disease. It actually initially enrolled with 5,000 men and women, and now it's on its fourth generation with about 15,000 participants. The study actually played a huge role in noticing trends in cardiovascular disease, and some of the most common ones was the normal BP that we typically consider, which is about 120/80. Cigarette smoking, high cholesterol, and obesity contribute to a very high risk of cardiovascular disease, and that exercise actually reduces risk of cardiovascular disease, which is something that we talked about earlier. On this slide, we have some screenshots of important documents.
Just go back one slide here. To me, the Framingham is an amazing study. So this actually took place in Framingham, Massachusetts. And you mentioned this is probably blue-collar Irish descent Americans. And this is how the United States tried to figure out what caused heart disease or not. So what was happening, there was a global pandemic of heart disease. And the question is why? So what they did is they started off with just 5,000 individuals. They brought them back on a regular basis. They measured your blood work, they measured cholesterol, your blood sugar. They didn't know what caused heart disease at that point in time. At one time, cigarettes were recommended to calm your nerves by obstetricians. We didn't know we thought the blood pressure was normal to go up as you aged. One time I was told when I was a medical student, your blood pressure should be 120 plus your age. That turns out to be wrong. It turns out that smoking is a very harmful maneuver. And we discovered, at least in Framingham, suggests that 90% of Americans, or for 90% of Canadians, will develop high blood pressure in one's lifetime. That means is that interventions you make today determine your risk of high blood pressure in the future. So one recommendation from this is everybody should think about getting a home blood pressure machine at some point in time and monitoring. Framingham estimates the risk of a heart attack or developing heart disease or dying from heart disease is somewhere around 50% for males and about a third for women. Now, as we're getting older, we're getting more heart disease and stroke, so we're living longer, which is good, but we have more chronic disease. And we found out that the best blood pressure is 120 over 80. We found out, and we're learning that the best cholesterol and blood sugar. So, you don't need fancy genetic testing for the average North American. If you're overweight, you smoke. In fact, the people who died in Framingham first, it's not that you had the highest cholesterol, highest blood pressure, risk factor multiplied risk. So the people that were dying first were those middle-aged males that were I'm going to start exercising next year. So they had a body mass index of about 30. Their stomachs arrived before they did, so that central big tummy. They had a little bit of blood pressure. It wasn't terrible. It was 140 over 85. Their cholesterol wasn't terrible. It was around 5. Just a few cigarettes. I'll exercise next time. Because risk factors multiply risk, and you can actually calculate, we'll show that in the next slide, is that you can actually calculate your risk, and Framingham usually gives you a 10-year risk of heart disease. And the good news is, as time goes on, our risks are decreased because we have better therapies. And so we talked about polygenic scores, but you can also just use Framingham data to calculate your risk, and that's how many physicians look at this. Now, I'm into lifetime risk, and I'm trying to combine all these risk factors in you, and I want to use the new fancy ones when you need the old ones. So the polygenic scores are relatively new. They're not here for prime time at this point in time, but we're going to be able to say in the future, Mrs. Jones, Mrs. Smith, your polygenic score for heart disease is 500. For breast cancer, it's 700. For Alzheimer's disease is 100, and this determines what you need to work on. It's like saying when you go to school, you have your strengths and weaknesses. So, for instance, one of my weaknesses is that I have diabetes, and therefore I need to exercise more, avoid all the white foods, everything that's white replaced with green. I have to exercise and be skinnier more. Because I have a genetic cholesterol problem, I would be foolish not to be on cholesterol early in life. And so these are things you need to think about. But Framingham really is a remarkable study. Don't need fancy genetics for that. It just needs some good approaches in looking at you smoke, you exercise, do you have high blood pressure, what's your blood sugar, what's your blood pressure, and what's your family history. Because if you have a first-degree relative who has a vascular event before the age of 50 or 60, your risk increases by at least 30% to about 50%. So, and you can also translate that to a vascular ages too as well. Let's go to the next slide.
Yeah, exactly. So just like Dr. Coronary was talking about, Framingham is a really great resource for calculating risk factor. So as you can see on the left side of the slide, it's sorted into men and women, so it's based on sex, and the scores vary based on your sex. So they take in factors such as age, LDL cholesterol, total cholesterol, your blood pressure, as well as if you are a smoker and if you have diabetes. And you calculate your total points, and it will then tell you your 10-year cardiovascular disease risk as well as your heart age. So it can be a really, really incredible tool for kind of measuring where you're at in life and where you are in comparison to someone who has a low risk factor. And also, it can also determine what type of treatment is required for you based on your score and based on the risk level associated with that score. So this is a great resource for you to just calculate at home, because you probably have all of this information somewhere in your portfolio, and you can evaluate your risk factor based on the general population statistics.
So everybody can get their lab results and just plotting how old you are, your HDL, your cholesterol, your blood pressure, smoking, diabetes. You can see these are yes, no, but they're all continuum of risk, and you get a generalized appreciation of the next 10 years, your risk of having a vascular event. Now, unfortunately, or fortunately, is that one of the big determinants of risk in Framingham is age. You know, if you're 20 years of, and Framingham actually starts at the age of 30, so that's when they start their study. So if you're 35 years of age, your 10-year risk is going to be low. And that's why where polygenic scores help you, because you can say your polygenic score puts you at high risk, so you have to start working early in life. The other thing you mentioned I really like about Framingham is that you can actually translate that into a vascular age. So for instance, what I did was when I was around 50 years of age, I put my Framingham scores. I'm a healthy person, I don't have to worry too much. My 10-year risk of having a vascular event was less than 10%. But my vascular age, the age of 50, was around 62. That meant my artery age at the age of 50 was that of a 62-year-old because I had a very positive family history. And that was a wake-up call to myself to get more active in this, and that's where I actually changed quite a bit. So that's why vascular age could be calculated, your overall risk, polygenic scores if necessary. So we can have a very good clue what your overall risk. Again, these give you the risk factors, as you point out, is the same genes in a different person will have tremendously different results. So I don't use these markers to scare people, but to inform people to learn how to decrease their risk. And very powerful tools, because we have now tools that we can actually lower your risk having a heart attack or stroke by over 2/3 with good lifestyle changes and good medications. And we have to decide together when the best time to start treatment. Obviously, the earlier you treat, the better off you are. Most of us wait till it's too late.
Exactly. So now that we've identified some of the risk factors and how you can calculate your risk, we also want to talk about some conditions that can arise from inheritance, and some conditions that you might want to keep an eye out for if you do have a family history. One of these conditions is arrhythmias, or irregular heartbeats. While they're not very common in terms of genetic inheritance, it is certainly possible, especially if you or others in your family have been diagnosed with arrhythmia at a younger age. So the Framingham Heart Study actually found that atrial fibrillation development was associated with parental atrial fibrillation. And the relative risk of atrial fibrillation for first-degree relatives of a family member was 1.77. And it was actually 4.67 if those relatives were less than 60 years old. So that shows a positive association between you and a first-degree relative with atrial fibrillation. In 2005, there was also a study that showed that 40% of individuals with lone atrial fibrillation that were referred to at a hospital had at least one relative with arrhythmia as well.
So for me, atrial fibrillation is the most common rhythm disturbance I will see. It's mostly a wear and tear of the heart seen in older people. So if you have high blood pressure, you're overweight, you've had a heart attack, you have valvular heart disease, you have sleep apnea, you drink too much alcohol, you have sleep apnea. These are things that put extra pressure on the heart, and it causes the pressure inside your right and left atrium to enlarge, and that causes the heart to fibrillate. Where younger people, if you have atrial fibrillation, you say before the age of 60, now a relative risk of 77% means that you're 77% more likely to develop this problem 4.6 means you're over 4 times more likely to develop that problem. But most of atrial fibrillation is a non-genetic problem. It's a wear and tear of the heart. But certainly you can have wear and tear on topogenic factors or just mostly wear and tear. So thank you for sharing that. Let's learn about more.
Yeah, exactly. So rare forms of familial atrial fibrillation, like we said, it's mostly due to wear and tear. However, there can be mutations in your potassium channel genes, and these are essential for maintaining the electrical stimulation in your heartbeat. So that is what causes these arrhythmias. And on the right side of the slide listed are a couple of rare forms of atrial fibrillation and arrhythmias as well that can be inheritable. So it's important to just check if you have a first-degree relative with any of these conditions.
What that means to most of us is that if you had a family member that unfortunately passed away, died suddenly, died in their sleep, multiple drownings in the family and good swimmers, and just suddenly collapsed. You have to think of entities that can affect potassium channels and sodium channels that can cause things like prolonged QT, short QT, polymorphic VT, Brugada syndrome. There's also some associated EKG changes. In fact, the most common cause of sudden deaths in young people is something called hypertrophic cardiomyopathy, which is a thickened heart muscle present around roughly 1 in 500 of us have the genes for it at this stage, and or have the presentation of that. So you can see that you want to combine a good family member. So if you have a family member that unfortunately passed away before the age of 35 or 40, talk to your doctor, because there might be a genetic factor in that. Obviously, if someone died unfortunately because of a drug overdose or some other forms, that's a little bit different. But that's why I have to be detectives, because unfortunately many times we're afraid to reveal the real truths and things of that nature as well. And the coroner right now actually, I think, keeps blood on people at some points in time. So sometimes we can go back and look at the DNA if necessary. But so we're learning a lot right now. Thank you for sharing that.
Okay, so next we're going to talk about congenital heart disease. So congenital means you've had it since birth, and there's different types. We're not going to focus on the specific types of congenital heart disease, but instead talk about the risk that they carry if you have a family history of this. So just to give an overview of different types, so there's congenital heart disease that involves valves, so like aortic and pulmonary valve stenosis, which is the narrowing of the valve. There's something called Epstein's anomaly, where the tricuspid valve doesn't form properly, and that's on the right side of your heart. And then there's tricuspid dysplasia as well. There's also septal defects. You have a septum between your left and your right atrium and your left and your right ventricle, which separates the sides of the heart. So a common congenital heart disease, one of the more common congenital heart diseases, is atrial septal or ventricular septal defects. There's also chromosomal abnormalities. So for example, trisomy, which is where you have more chromosomes, so things like Down syndrome. There's also Williams, Turner's, Marfan, and DeGeorge syndrome, which are other chromosomal abnormalities that can cause congenital heart defects. And there's also a category that's kind of remnants. So the fetal heart system works a little bit differently, and it's structured a little bit differently because it has a different purpose than our regular adult system, because they are connected to the mother, and there's different things that are modulated through being in utero. So when some of those different anatomical elements they don't develop properly, or they aren't resolved when the child is born, you can end up with things like a patent ductus arteriosus, or the coarctation of the aorta, or something that's called tetralogy of Fallot, which is a rare condition but does occur. And so these are just some broad categories of congenital heart disease.
Complicated words, and basically congenital heart disease, and anybody in your family who has had increased risk, not always for the same genetic abnormality, but they're more associated with congenital effects. And obviously the more severe, the more likely you to present. So today, for instance, I saw a patient who's 70 years of age. At the age of 48, because a friend unfortunately died of heart disease. He wanted to be screened, and part of his screening, he had an echocardiogram that showed a big hole in his heart. He had an atrial septal defect. It was a big one that was not appreciated before for the first time. He was totally asymptomatic. That got closed because if it didn't get closed, that would have been associated with damaging of his right side of his heart, pulmonary hypertension, and his life would have been shortened, but they caught that in time to look at that. The most common congenital heart disease that I see is something called a bicuspid aortic valve. Turns out that most of us have 3 leaflets of aortic valve. About 1 to 2% of us have a 2-leaflet valve, and that tends to wear out earlier. It's also associated with disease of the aorta. The elastic or the glue of the aorta is not as strong. So these are things that we can actually pick up and image, so the echo can be helpful for looking for that. And as we get older, many of us, at least 25% of older people, will have some sort of valve problem. A lot of it being wear and tear over the time, and you're asking your heart to pump at least 60 times a minute forever. It's remarkable that the heart can adapt so well. So take care of your heart. Know your blood pressure, know your weight, know things how to protect your heart. So remember is that I find this amazing that 90% of people in Framingham or 90% of Canadians will develop high blood pressure in your lifetime. And if you're going to wait for your stroke to take place, you're in trouble. I remind people for every 10 millimeters reduction in blood pressure, fatal cardiac events fall by 10%, heart attacks by 20%, strokes and congestive heart failure by 30%. So please, 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 learn to measure your blood pressure. We have a lot of webinars on that. So there's businesses that don't have high blood pressure. 90% of us living in North America will develop high blood pressure over a lifetime. It's an asymptomatic disease for many decades. So take a look at that. Thanks a lot. Next slide, please.
So just a little more about congenital heart disease. So as I mentioned, congenital means present from birth. It's one of the most common types of birth defects, and about 1% of children are born with a congenital heart defect. According to Harvard Health, one of the most common types is the ventricular septal defect. So there's an image of that on the side, where it's basically a hole between your 2 ventricles, and your left ventricle has a lot higher pressure than your right ventricle, so you get the shunting of blood to the right, which can cause a whole slew of conditions, including like an overload on the right side of the heart. So why do congenital heart defects occur? Well, there's no obvious cause. It's a lot of different factors that contribute to it, but there are some risk factors and contributing factors that have been identified that can cause CHD, and we'll go into that on the next slide. So if you have a congenital heart defect, there's a 3% increased risk that'll be passed on to the child. So when your first degree relative has a congenital
Three times increased risk.
Yeah. Mm-hmm.
Yeah. So 3 times higher.
Mm-hmm. So some of the defects are autosomal dominant. So what this basically means is that it affects males and females the same, and you have dominant and recessive genes. So dominant genes are the ones that get expressed, recessive are the ones that don't get expressed unless you have 2 recessive genes. So what this essentially translates into is that there's a 50% chance of inheritance associated with some congenital heart defects. So genetic causes for CHD are usually chromosomal abnormalities, so having too many chromosomes. We should normally have 46, but there are some instances where you have less than 46 or more than 46. And there's also single gene defects, so monogenic genetic conditions. If you have a family history of a congenital heart defect, speak with your physician and healthcare provider. And one of the things that's recommended is fetal echocardiography, which is done in the 2nd trimester for pregnant women. And it can actually detect some major heart defects if it's done at this point in time, which can kind of inform the way that a mother goes through the rest of her pregnancy and what they need to prepare for when the child is born. So there are some maternal factors as well to consider with CHD. diabetes, alcohol, and smoking, family history of genetic diseases or CHD, anti-seizure medications or lithium as an antidepressant, being on a specific type of diet, lupus or connective tissue diseases. If the mom has any of these conditions, there is an increased risk for something to go wrong during development leading to a congenital heart defect. So again, something to note with respect to family history and congenital heart defects. And if you have a family history or have been diagnosed with any of these conditions, let your physician know so that it informs the fetal and perinatal care. So next we're going to talk about cardiomyopathy, and cardiomyopathy is a disease of the heart muscle. It affects the way the heart muscle works, making it harder for your heart to pump, which can lead to heart failure. There are 3 different types. We're going to be talking about hypertrophic and dilated cardiomyopathy. There's also restrictive cardiomyopathy, which is usually associated with aging, where the heart muscle becomes less elastic, so it's not able to pump as well. So there's just an image below that shows kind of the different types. So in a normal heart, when you compare that to a hypertrophic heart, that's a very thickened muscle, and then in dilated, it's actually the opposite, it's thinning. So for familial hypertrophic cardiomyopathy, this is the thickening of the heart muscle, which makes it harder for the muscle to work properly. Familial HCM is inherited, and it's usually the thickening of the interventricular septum. It can restrict flow of oxygen-rich blood to the heart and also lead to a loss of efficiency when pumping, and it's caused by a mutation of multiple genes, usually involving the proteins that form sarcomeres, which are part of the heart muscle. And then for familial dilated cardiomyopathy, the heart muscle becomes thin and weakened, so that causes the dilation and the enlargement of that chamber. The heart cannot pump blood efficiently. It attempts to increase the amount of blood it's pumping to compensate, which further weakens the muscle. For a dilated cardiomyopathy, it can take years to develop, whereas with hypertrophic cardiomyopathy, if it's inherited, you can commonly see incidents in adolescence or young adulthood. It's kind of a notorious type of cardiomyopathy for cutting down like athletes in their prime, is the way some people describe it. And for dilated cardiomyopathy, it can be caused by mutations in more than 30 genes. So familial hypertrophic cardiomyopathy is inherited through autosomal dominance. So as I'd mentioned earlier, it means that there's a 50% chance of inheriting it if one of your parents is affected. Many people can be symptom-free or have mild symptoms, but this condition can have serious consequences, and it affects about approximately 1 in 500 people. So clues to look for if you do have like a family history of hypertrophic cardiomyopathy and you're being screened for it is shortness of breath, syncope or dizziness, chest pain, and palpitations. And if you have a family history or if you've been diagnosed with hypertrophic cardiomyopathy, you need to kind of involve your physician in the conversation so that they can prescribe adequate screening and diagnostic tests. So for example, yearly echoes can help monitor muscle growth, which can lead to early intervention. And below I just posted the guidelines. One is an American set of guidelines, the other one is from the European Cardiology Society, and they recommend every 1 to 2 years screening adolescents into young adulthood with echoes to monitor the muscle growth, and communicate this information to your family and your children so that everyone can get the appropriate screening or genetic screening if necessary, and ask questions. So as I mentioned, hypertrophic cardiomyopathy is kind of known for cutting down athletes or young people in their prime, so ask about exercise and lifestyle before making any changes, and that can be really instrumental in kind of prolonging your life.
So the real signs that I worry about is, again, back to your family history. So if your father unfortunately passed away while playing baseball at the age of 25 or 35, that would be a tremendous warning sign. Number 2 is that we all get dizzy or all short of breath. But the things that worry about is that you're running down the street, you're exercising, and you pass out without warning. Or you pass out while you're sitting not doing anything. These are more likely to be very serious conditions. Get up quickly and get dizzy. Well, don't get up quickly. Get up slowly. I get dizzy after I drank too much. But the warning signs, again, look at your family history and look at exertional-related symptoms. And basically, if you pass out without warning with activity, that's important. Exercise induced is important. Or just while you're sitting doing nothing without warning, you pass out. That really requires very urgent care to make sure that you don't have a serious rhythm problem of your heart.
So with familial dilated cardiomyopathy, it's also usually inherited in a dominant pattern. So I have an image of that. It's not a proper pedigree because they have people instead of boxes and circles, but it just kind of shows that the red people are affected. So it can be inherited in a dominant manner where there's a 50% chance of inheritance. There are some rare cases where it's X-linked, so that's linked to the X chromosome, or a recessive inheritance, but those are incredibly rare. With dilated cardiomyopathy, some people actually expressing any of the features of dilated cardiomyopathy. And important clues to consider is a history of heart failure or the symptoms of shortness of breath, fluid retention, and swelling and fatigue within your family, unexplained sudden cardiac death or arrest, muscle problems, arrhythmias, palpitations, syncope, young age of onset. So if any of these things exist within your family, whether or not it's been diagnosed as dilated cardiomyopathy, it's a red flag and something you should mention. And if you have dilated cardiomyopathy or family history of it, then make sure you tell your physician so they can prescribe the adequate screening. Make sure you communicate this to your family members so they can get adequate screening as well. For dilated cardiomyopathy, the screening tends to be every 2 to 3 years, and early intervention with medications can help sustain and preserve the quality of life. And make sure this information is communicated with family members, and so that people are able to get screening or genetic testing as well if they choose to do so.
So now I'll just be talking about familial hypercholesterolemia, and familial hypercholesterolemia, or FH, is an inherited disorder that makes it harder for your body to remove that bad cholesterol, the LDL, from your blood. And as a result of this, cholesterol kind of builds up along the walls of your arteries and veins, narrowing the passageways and drastically increasing your chance for a heart attack or stroke at an early age. And there can be physical signs of FH during a clinical exam, although not everyone with FH has these signs. So these signs occur when extra cholesterol builds up in different parts of the body. So you can see or may feel bumps or lumps around your knees, knuckles, or elbows, swollen or painful Achilles tendon, or see yellowish areas near your eyes, a whitish gray color in the shape of like a half moon on the outside of your cornea. And the risk of FH is higher if one or both of your parents have the gene defect that causes it. And most people who have the condition have one affected gene, but in rare cases, a child could get the affected gene from both parents. And this can cause a more severe form of the condition. So FH can be diagnosed both clinically and genetically, and FH is usually diagnosed clinically with the lipid test that measures the amount of LDL cholesterol in the blood, a physical exam, and a family history. Genetic testing is done for the 3 currently known genes that cause FH, and since FH is passed down from generation to generation, if a genetic variant has been found, then genetic testing for that specific variant can be used to test other family members as well, and that's called family screening or cascade screening.
It's quite interesting. There's hundreds of mutations to the FF gene, but they could be on different parts. When you mean three parts, we're talking about the LDL receptor, the PCSK9, or some of the translation parts to that as well. So LDL cholesterol turns out to be a bad cholesterol. We have a whole webinar on that, and we have actually a talk on genetics as well to take a peek at that for more information. That's probably the most common genetic abnormality that's seen in North America. Somewhere present around 1 in roughly 200 people in Ontario, and probably more in Quebec, 100, 150, because of the founder effect that took place when people came to populate Quebec.
So I'll just be talking about Canadian guidelines for cholesterol. And so the Canadian Cardiovascular Society's guideline for managing abnormal amounts of lipids in the blood for adults to prevent cardiovascular disease recommends pharmacologic therapy with statins for high-risk groups, including those with clinical atherosclerosis, abdominal aortic aneurysm, diabetes, chronic kidney disease, or LDL cholesterol levels that are higher or equal to 5 millimole per liter, as well as Framingham's risk score of greater or equal to 20%. For primary prevention, a risk assessment is required, as those with a risk score of less than 10% don't require pharmacotherapy, and a fire and forget strategy is inappropriate. So, for example, that would be when there's treatment done without follow-up blood tests to monitor lipid levels. And for those at intermediate risk, there is consideration of therapy based on other factors such as LDL levels of less than or equal to 3.5, non-high density lipoprotein cholesterol of less than or equal to 4.3, or men aged 50 years or older and women aged 60 years or older with one additional cardiovascular disease risk factor. And as Dr. Cree mentioned,
as we talked about, the Canadian guidelines were about 2016. Since then, there's been an evolution to that. So the most up-to-date guidelines are probably European guidelines and the American guidelines. The Canadians are coming with new guidelines in, this year, hopefully. And we learned is that lifetime risk is actually more important than just 10-year risk of heart disease. So we had something on cholesterol in more detail. And in fact, what I've learned is that if Framingham underestimates genetic risk by about threefold. So that's why that genetic and knowing your cholesterol and speaking to an expert in that matter is really, really important about that. So why don't we just move on to the next phases of things. And we'll talk, I just refer everybody to the genetic workshop that we did and the cholesterol one that we had too as well, because so much to learn about that. I want to spend more time here about just the genetics right now. So let's just move on. Is that okay?
Mm-hmm. Next is coronary artery disease, and this develops when major blood vessels that supply your heart become damaged or diseased, and it's caused by cholesterol-containing deposits, so like plaques in your coronary arteries and inflammation. And coronary arteries supply blood, oxygen, and nutrients to your heart, and a buildup of plaque can actually narrow these arteries, decreasing that blood flow to your heart. And as a result, the reduced blood flow can cause chest pain, so angina, shortness of breath, or other coronary artery disease signs and symptoms. And a complete blockage will then lead to a heart attack. And because coronary artery disease often develops over decades, you may not notice it. You may not notice a problem until you have a significant blockage or a heart attack. And some symptoms of this disease are, as I mentioned, chest pain and shortness of breath and heart attack. And some causes for coronary artery disease are smoking, high blood pressure, high cholesterol, diabetes, and a sedentary lifestyle. And then the risk factors of coronary artery disease include age. So getting older increases that risk of damage in narrow arteries. Sex, men are generally at a greater risk of coronary artery disease. However, women, the risk for women increases after menopause. Family history is important because it's associated with a higher risk of coronary artery disease if there is family history of it. Smoking, high blood pressure, high blood cholesterol levels, diabetes. If you're obese, excess weight typically worsens other risk factors. Physical inactivity, high stress, and unhealthy diet. So eating too much food that has high amounts of saturated fat, trans fat, salt, and sugar can all increase your risk for this disease. And risk factors often occur together and one can trigger another, so it's important to be health conscious when making your lifestyle decisions since it can lead to unwanted outcomes. And the same lifestyle habits used to treat coronary artery disease can also help prevent it. So a healthy lifestyle can keep your arteries strong and clear of plaque. And to improve your heart health, you should quit smoking, stay physically active, eat a low-fat, low-salt diet, manage your stress.
Sorry, I was on mute again. So we also wanted to touch base on conditions that might not necessarily be directly linked to cardiovascular disease, but can also have a huge impact on quality of life as well. And some of these conditions do have an inheritable factor and a genetic predisposition as well. So dementia is a really common type, and it can be affected by inheritance. So Alzheimer's is a really common form of dementia. However, in 99 out of 100 cases, Alzheimer's is not inherited. However, the 3% of people that do develop Alzheimer's, especially those who develop it at an age that is less than 60 years, are much more likely to have gotten Alzheimer's from a faulty gene that was passed directly from parents to children. So that is something that is important to note, that if you have people in your family who are young with Alzheimer's, that there is potential for a faulty gene that causes potential risk. Another form of dementia is vascular dementia. This one in itself is not inherited. However, it's important to note that the underlying health conditions can contribute to the progression of this disease. And these include high blood pressure and diabetes, and these are factors that can be passed on from one generation to another, as we mentioned a little bit earlier. Another common form is frontotemporal dementia. It's not directly inherited. However, 40% of people who do develop the condition will have at least one close relative diagnosed with some other form or potentially the same form of dementia, which can include FTD, Alzheimer's, or ALS as well, which is also known as motor neuron disease. This disease is polygenic, so genetic testing is the best way to find out if you have a gene that is causing your frontotemporal dementia. There are also rarer types of dementia that actually do have a pretty heavy genetic factor that contribute to them. The first one is Huntington's disease, and the second one is familial prion disease. And these have a 50-50% chance of being passed on, caused by a single faulty dominant gene. So we explained that a little bit in the beginning, but it's basically a 50% chance of inheritance if you do have one parent with the faulty gene. So if you inherit the healthy gene from one parent and a faulty gene from another parent, the faulty one will always be the one that is used because it is the dominant gene. For more information and care and support services, you can refer to the Huntington's Disease Association or the National Prion Clinic that is available at the University of CL. So another one that we also want to touch upon is cancer. So cancer is a very, very common disease now, and we have discovered that there are several genetic makeups of cancer that can be passed down directly. For example, in breast cancer. So that's one that's really common, where they've actually isolated genes for breast cancer, and you can be genetically tested to see if you do have it. There are over 200 different types of cancers, and they depend on where in the body that they originate from. Cancers, in a broad overview, are caused when cells in the body start to grow and divide uncontrollably and form abnormal clusters of cells called tumors. And these tumors can originate and impact different parts of the body and different organs in the body. So understanding your cancer risk comes with several components. You can understand your risk factor, which includes aging, the use of tobacco, obesity, alcohol, exposure to different viral infections, chemicals, and radiation. However, the one that we want to really hit on is a genetic history. This is because 5 to 10% of cancers are caused by directly inheriting a gene mutation from your parents. So people with an inherited gene mutation have a higher risk of developing cancer, especially at a younger age. And this means that those who do have a family history, especially a direct relative that has cancer, should consider genetic testing. There are different types of screenings depending on what type of cancer. However, it is encouraged that those with risk factors undergo routine screening to catch the disease early on.
So, if we just backtrack one slide here, what this tells me is that most of cancer is an environmental factor you can control. You know, if you smoke, you have a 60% chance you will die from a smoking-related illness. We learned right now that alcohol is a type 1 carcinogen. And to me is that we talked a lot about genetics, but to be honest with you, is that a lot of this stuff is not ready for prime time at this point in time. What's really available for prime time is you need to think of your weight, your exercise, alcohol, tobacco, and you know, if you're working in a certain industry, make sure you have the right types of protection and things of that nature. So I'm really optimistic is that there's so much that can be prevented. We spent a lot of time talking about genetics, but if you go back to basic principles, is every day your body makes cancer cells and your immune system gets rid of cancer cells. Now you want to make that work really well, so exercise, keep your weight down, don't drink more than 3 drinks a week or less. You know, if you smoke, let's think about stopping smoking. And the genetic screening, while it really sounds really sexy and it's like the right thing to do, is that I don't think you need to do that for the vast majority of us. It's just one of those, when you mentioned those earlier disease happens early in life, and it gives you that extra incentive to push yourself a little bit harder. So let's go to the next slide. And this is wonderful news. Is that so it can be both scary, but it's also exciting that you can do so much to lower your risk.
Exactly. So we want to touch upon that as well. The slide is over here. Elena, take it away.
Yeah, so to gauge if you have family history of heart disease, it's kind of important to look at 2 things. And the first thing is to identify which member of your family has or had heart disease and their age when they were first diagnosed. So if one of your immediate family members, such as a parent or a sibling, has had a heart attack, stroke, or was diagnosed with heart disease before the age of 60, this may indicate a family history of premature heart disease. And this means that your chances of developing the same condition may be higher than normal. And on the side, I've listed some resources that are available, like 23andMe and Ancestry Health, and 23andMe can give you a personalized report breaking down your genetic data and lets you see how DNA can affect chances of you developing certain health conditions like FH. And similarly to this, Ancestry Health can detect 80% or more of known DNA differences that are linked to conditions related to high cholesterol like FH or heart risks like cardiomyopathy and other stuff as well.
I'm not sure we're quite as good as you think we are yet. So I think is that a lot of these things are being discovered as we go along. I'm privileged to work with some people that keep informing me what to do, and where this fits in at this point in time, I'm not sure. I'm more impressed with the preventive aspects of things and being a good health detective. I'm less impressed with all these commercial kits just yet, and but there's still a lot to learn about at this stage of the game. And you know, when I first started, there was no such thing as a polygenic score where you have hundreds and thousands of genes all contributing. So, for instance, myself is that I have a polygenic score that's very high for cholesterol and triglycerides. I know I have a high cholesterol and triglycerides. What came to me as a new revelation is that I have a high Lp(a), which is a new genetic marker that's present in also other of my family members. So that makes me be more aggressive in my cholesterol management. Because I have diabetes in my family, is that I have to be better than most. Is that one of the predictors of diabetes is don't get older and don't get more overweight. But you know what? I'm getting older, but I'm getting faster and skinnier, and I'll keep working at that. So there's so many things you can look at. And so taking advantages. I know that most of us have blocked arteries or start to develop blocked arteries in our teenage years. We already know that. And so the question is, predicting a heart attack, we're not very good about that, but we're very good at stacking the odds in your favor. So all this means is if you have a positive family history and sometimes some genetic traits, you just work harder.
That's exactly right, and that is the main message that we do want you to take away. So just to summarize, we want to help you understand the importance of family history as a preventative measure. So keeping a complete and accurate portfolio will help you be more aggressive in your prevention and help you to lead a healthier lifestyle. It's essential for understanding risk because your family members do share your gene, but they also share your lifestyles, your habits, and your environments as well. And your physician can also use your family history to recommend strategies and therapies for risk reduction and identify who is at risk for what conditions. For us to understand how genetics impacts our health, we need to know about the building blocks of genetics, DNA. DNA sequences are called genes, which code for traits, and mutations in inheritance can cause conditions to be passed down through generations. These are called genetic conditions, and they can be monogenic or multifactorial. We can use our genes and DNA to determine our risk factors. For complex diseases, we use genetic information to find our polygenic risk score, which explains the relative risk of a disease. However, one of the best and easiest tools is the Framingham study on calculating risk. You can identify your score and identify your 10-year risk of cardiovascular events, as well as your heart age. We also covered several inheritable conditions today. The first is arrhythmias. Even though there's a small relative risk of atrial fibrillation, it can be caused by mutations of your potassium channel genes if you have a relative with atrial fibrillation. We also discussed congenital heart disease, which are various birth defects that affect the way your heart works. Although there is not always a direct cause, we know that there is a 3 times increased risk for cardiovascular disease when a first-degree relative has a congenital heart defect. Our third condition we discussed was cardiomyopathy, which is a disease of the heart muscle, which affects its ability to pump blood. Familial hypertrophic cardiomyopathy is inherited through autosomal dominance with a 50% chance of inheritance. It usually causes the thickening of the interventricular septum, and it can cause thickening of the heart muscle overall. Familial dilated cardiomyopathy is inherited through multiple gene mutations, and it causes the dilation of the chamber by weakening and thinning out the heart muscle. It's important to identify if you do have a family history of cardiomyopathy, especially if the victims are younger. We also discussed familial hypercholesterolemia, which puts one at risk if one or both of the parents have a gene defect that causes it. One more condition that can be inherited is coronary artery disease, which is polygenic. The risk factors that lead to coronary artery disease can be impacted by family history and by environmental factors, such as high blood pressure, high familial hypercholesterolemia, and a predisposition to diabetes. When we are identifying cardiovascular conditions in the family, it's important to identify the members of your family that have the heart disease as well as their age when they were first diagnosed. If an immediate family member had a heart attack, a stroke, or was diagnosed with heart disease before the age of 60, it might indicate a family history of premature heart disease. Personalized reports of your genetic data, although not always accurate, can be obtained from sources such as 23andMe and Ancestry.ca. However, these are great tools to just get you started on a healthier lifestyle. Finally, some conditions that are not necessarily cardiovascular but can affect your quality of life are dementia and cancer. Some rare forms of dementia, such as Huntington's disease and familial prion disease, are caused by autosomal dominance. 5 to 10% of cancers are directly caused by inheriting a gene mutation from your parents. Therefore, it is recommended that those with a family history of cancer do consider genetic testing for cancer risk. So as you can see, family history, in addition to environmental factors, play a huge role in predicting health outcomes and managing risk. Therefore, we hope that you take the message of this webinar, sit down with your family, construct a family tree, and start the new year off with keeping your family healthy and aware.
So that's wonderful news. I want to just stress is that genetics have been around for a long time. They haven't made as a great impact as we want to at this point in time because it's much more complicated. So the average physician doesn't know enough about genetics. So if you think you have a genetic abnormality, you might have to see a genetic counselor and proper interpretation of the data. For instance, I see people with hypertrophic cardiomyopathy. Almost all of them are managed without ever having genetic testing, because we look how thick the heart muscle is, we look at their stress test, their arrhythmias, and their history. For familial hypercholesterolemia, a genetic abnormality, LDL receptor, the vast majority do not need to have genetic testing. I know for most of us, it's nice to have that information. At some point in time, I'm going to get my whole human genome sequenced, but I'm not going to do it yet because I don't know how to fully get the proper best information about that. But if you had someone with early deaths in the family before the age of 35 or 40, someone who's passed away in their sleep, or you've had multiple family members with early heart disease or stroke, I would be very aggressive in your management of risk factors and make sure that you work on prevention. When it comes to cancer, is the thing you can prevent cancer by keeping your weight down. Unfortunately, as you gain weight, especially around the midsection, it causes these things called cytokines, inflammation, that unfortunately increases cancer. You know that an unhealthy high-fat diet increases the risk of colon cancer, increases the risk of breast cancer. So, instead of measuring genes, just change your lifestyle. If you smoke, stop. If you can't stop, get help or reduce. And, knowing basic things such as your cholesterol and your blood pressure is that, if we do things well, the average human may be able to make it to the age of 120 or so. So that's basically the projected longevity if all things happen in the way they should, and a bit of luck right now. So I'm really excited about what we discovered. We now know that the genetic makeup of COVID, and we're going to learn more about how infections affect our health in general. And I'm also impressed at vaccinations. I wish there was a vaccination against many of these diseases. What we know so far about COVID is it looks like the vaccinations are somewhere between 80 and 90% effective. That's remarkable. I know of nothing that can prevent disease to that same degree. So I don't know about you, as I'm looking for my COVID vaccination, and I'll get the first vaccine that it's available out there. And I want to just thank the scientists and the drug companies in the world for in such a fast manner of putting all together. I'm also learning a lot about genetics. I have a lot more to learn about this, and I thank everybody for sharing these insights. Stuart, are there any questions out there that people posted or comments, or are people just stunned?
No questions right now.
Yeah. Is there anything else anybody has to say? I think it's wonderful. Don't overuse genetics. Use the environment to make sure you don't express that. To me, what determines your risk is how hard you're willing to be healthy. And hard work and being healthy is the basic principles. It's the same thing with anything. Hard work leads to good things, and have fun doing it. So remember, we're doing our stairs on Mondays and Saturdays at Shadok. If people want to join us at 6 o'clock in the morning, know your Framingham score if you want to, but measure your cholesterol, learn how to keep track of your information, and selective genetic screening is appropriate. What we showed today is that the potential for genetics, for most conditions, we don't fully understand this yet right now, and I'm just totally amazed what I've learned and yet to learn at this point in time, and how things will change. I want to thank everybody for wonderful insights. Anything else anybody else wanted to add to this at all? I think the important thing is that when we first started, when you saw people's goals of activity and goals of weight, goals of eating, goals of exercising, knowing your blood sugar, blood pressure, and if you smoke, really work at reducing that. It sounds so easy, but it's so hard. And I'm having more fun doing it than ever. Stuart, you get the last word.
Well, I was going through the slides again, and I was trying to decide what I wanted to talk about in my little wrap up. But I think the team did a really great job of emphasizing that DNA is just one thing, but in the grand scheme of things, it's all about prevention. So whether you have a high family history like yourself, Dr. Kernu, or you have perfect genetics, you can always still have cardiovascular disease. And half the battle is a proper lifestyle, proper habits. And the one takeaway I'd potentially have is that everything's a little bit more fun when you do it as a team. So, if anything, I would recommend being your family Sherlock Holmes. You can use this video as a conversation starter with your loved ones, your friends and family, to show them, hey, look, genetics is one thing, but doing healthy habits and having good New Year's resolutions to take care of my health, take care of my happiness is important too, so I can live longer and be around long beyond this pandemic. So the bottom line, I like at the bottom of the slide here that Dia mentioned, start the New Year's with keeping the entire family and friends healthy and aware, and you can use this video as a way to start those conversations. The last thing I will say is that we have a great team here who worked really hard over their holidays to put this video together, and Dr. Kernu and I and everyone who's watching, I'm sure, are more than appreciative of all the effort that went into this. There are so many people on this team, but also people behind the scenes that you don't really see all the time, who are working really, really hard at this clinic. So I would say that if you enjoyed this, if you found this video helpful, I would say tell your friends. We use the same link for our WebEx every single week. You can always find us on our YouTube page. That's not going to change. So if this is something that interests you and you found this helpful at all, I would certainly advise you to reach out to any of your loved ones and let them know of this information that we're trying to share, because at the end of the day, this is all for you, and we want to make sure that you're getting the most out of it. So we appreciate you for joining us here this Friday, and we look forward to hopefully seeing you soon.
Good night, everybody.
Good night, everyone. Take care.